Welcome everyone. Today I will be sharing my thoughts and insights about the accuracy of digital impressions and bite registration in full arch implant cases. I'm Justinas Pletkus, prosthodontist, PhD at Vilnius University, and I hope you'll have a really productive time listening to this lecture. So, going briefly in this lecture will be divided into two parts. In the first part, we'll talk about accuracy of digital impressions in full arch implant cases, and in the second part, we'll touch upon bite registration, which is oftenly mislooked, and the research is not that great compared to full arch scan accuracy. And throughout, I will share some research that is relevant to this topic and also include research that we've done with our research team. So to get through the workflow, digital workflow for a full arch case, this is quite pushing the limits of the technologies that we use daily in our practice. So we know that scanning implant cases for single restorations or short span bridges is viable, and I think we're getting to the point that there is no discussion what to choose, digital or analog. But regarding these complicated cases for full arch extensive restorations, there's still lots of hesitance from the clinical practitioners, and in the research field, the number of publications is quite large, so it indicates that there are some pain points and accuracy debates on how well can we trust these technologies in producing these kind of restorations on implants. Some background to get introduced into this topic. So we need to understand that the process of full arch implant restoration is quite comprehensive. So we have two main stages where everything is happening. So at the dental office, we have data acquisition appointment where we can take photos, gather all the information needed for the dental technician to manufacture this kind of prosthesis. And in the dental lab, there's a whole chain of processes going on to produce the beautiful teeth for the patient, involving CAD and CAM processes, and also finalizing everything to look nice and natural. And at the end of the workflow, we get back to the dental office for the delivery. So in every step of this process, we can have errors, and we'll stick to the data acquisition appointment today, and we'll talk about, in my mind, one of the two most important aspects that could influence the overall finished product of full arch implant restoration, that is data acquisition. So, bite registration and implant scan parts. So there's an ISO standard that talks about the accuracy, and accuracy is oftenly not understood well, and I would like you to clarify this concept of the accuracy according to the ISO. So we have two parts that combine to the term accuracy. So this is trueness and precision, and as you see from the image, we can have a highly true results coming out from our scanners, but with low precision. So the average value will be quite accurate, but every now and then you'll get deviations that could significantly impact the overall success of the restoration. And for the cases and scanners, when we can have high trueness, but we lack precision, then you can also expect errors, and these errors will be always in the same field. So, for example, 10 scans, and every scan of these 10 cases will be shortened three-dimensionally, or shrunk in three-dimensional area. So we strive for high trueness and also high precision, and then we can call that our workflow is highly accurate. So what is this accuracy of digital full arch implant cases? How can we say that this workflow is clinically acceptable? What deviations we can expect? 0 microns is probably the threshold that we all want, but realistically, we will not get there. So, and then there's a discussion, what is clinically acceptable? 20, 100, 150 to 150 microns. So we'll talk through this. But as mentioned in great systematic review and meta-analysis by Shengzhen Chai et al., so we see that figures coming out from research suggest that we should expect somewhere between 50 and 200 plus microns of deviations, depending on the environment in which we produced these tests. And this is quite large deviations, and I would say that 50 microns is considered to be the threshold that we can see the misfit of the prosthesis if the gap between the implant platform or multi-unit abutment platform and prosthesis is more than 50, 100 microns. So interestingly, so we know what can we expect in the clinical practice, what kind of deviations we can get in the digital workflows for full arch cases. But it's also very important to understand that there are some clinical aspects that we need to keep in mind if we want to reduce the deviations that we produce during the workflow of data acquisition. So, as mentioned in narrative review by me and our colleagues, and also in a nice publication by Reville Leon et al., we have two basic categories of clinical aspects that we need to keep in mind. So, biological and technical. And according to these, the main problems are that we have a lack of reference points. The tissues that we're scanning are oftenly mobile. We deal with saliva and all kind of reflections in the mouth due to wet surfaces, and also, of course, the burden of our profession is limited space in the mouth. And then there's technical aspects, and this is the whole lecture about these top topics. This includes scan body design, scanning time, the stitching algorithm that is behind the scenes, and this information is oftenly not available to the dentist and researched because it's under the companies that produce these machines for scanning. Also, we have complex workflows that is really sometimes hard to fulfill. And then we have implant angulations, and different systems of implants deal with this differently. Also, same as stitching algorithm, we have post-processing. We need to know what's going behind that process, and also all sorts of other technical aspects that we should always try to look for. So knowing that all those aspects that we come up in our clinical practice, and the research tell us that we are not there yet in terms of the accuracy for full arch cases using only digital dentistry tools. So can we improve the accuracy? And if yes, then how? So the first thing is we can do is use some sort of stitching of the scan bodies. This can be done using really simple tools like dental floss or rubber band intertwined between the scan bodies, or the solution from OptiSplint is to have a dedicated space where you can stitch all the surfaces of these scan bodies to have closer approximation and also more space to align the information for the scanners. The second one is horizontal scan bodies. This is intertwining a bit with OptiSplint system, where you can splint all the scan bodies not only by digital scan but also mechanically, and have a fixed mechanical information about the implant position for the master cast. But there is a recent surge of companies that produce these horizontal implant scan bodies, which helps intraoral scanners to produce more accurate results. And also we have photogrammetry devices that we can rely on, but these are more pricey and can be used in those dental clinics where the main focus is full arch cases. So then it becomes a sensible investment. But recently, some intraoral scanner companies introduced scanners that have algorithms and hardware solutions to have some sort of hardware and software algorithms to deal with full arch implant cases and with promising results. But yes, as with all new things, we need some research, and we need to have some proof behind these concepts. Also, we can use prefabricated or fabricated individually for the patient stents that optically connect these scan bodies, and they can be used also as a reference for the BITE registration as well. And we'll talk about this in a bit. But this is also an option for improving the overall accuracy of our intraoral scanner full arch implant case. And the last one, the method that needs to be discussed and briefly introduced is a reverse scanning technique, where if we have a really passively fitting temporary prosthesis, we can utilize this and scan it intraorally fixed to the implants, then remove it from the mouth, put these special scan bodies that attach to the intaglio surface of the abutments in the temporary prosthesis, and the dental technician can merge all the information and get the accurate position of the implants in relation to the mucosal scan that we do in the patient mouth. And this is a mixed method, really convenient, easy, and cheap. And we wanted to try to look how it affects the accuracy of implant scans. So we did in vitro study with fiducial or reference objects glued to the surface of the gingiva in between the implants. And we used a reference scanner, the high precision Nikon Altera scanner, and a number of commercially available intraoral scanners to scan with and without these reference objects, and we measured the distances between the scan bodies and also the angulations between few of the scan bodies. As a result, we've noticed that in full arch edentulous cases, digital splinting made no statistically significant differences in both trueness and precision. And tendency was that the longer the distance between the scan bodies, the bigger the deviations occur. So this means that we should not rely heavily on those simple methods of digital splinting, reference objects, flaws between the implants, because these objects don't produce geometry that is sufficient for the intraoral scanner to better and more accurately scan the edentulous area between the implants. Some future considerations and insights from me. So, as you've noticed, we cannot rely solely on intraoral scanners and standard scan bodies to produce every single time well-fitting passive final restorations on full arch implant cases, but we need to employ some additional workflow measures to improve the accuracy, and then we can get those numbers that we strive for. But having in mind that we make our workflow a bit more difficult and time consuming because of the extra scans, supplementary scan bodies, prefabricated or customly made devices. Also, the knowledge of the dental technician and dental professional should be up to its standard to utilize all these things. And also regarding the research on these topics and the accuracy of these cases, there is a big struggle, even though the number of scientific publications is large, but we don't have standardized way to assess the accuracy of these kind of procedures, and we have difficulties in getting information from the manufacturers on how these post-processing and stitching algorithms work. So there's definitely a space and a need for these kind of research in the future. For the second part of the lecture, we'll touch upon digital bite registration of these kind of full arch implant cases. And we deal with all sorts of situations and dentism in our clinic, ranging from patients that don't have good looking or fitting restorations, either removable or fixed. So putting in implants, scanning, and then we need to come up with a good looking temporary solution for them in the healing period. Also, we have situations where patients have only a few teeth left, and then we put implants, and then yet again we have to convert to a fully implant supported restoration with good occlusion and aesthetics. And the majority of cases are those where we have some sort of temporary occlusion and aesthetics, and we then convert it to a better one or the final restoration. Yet again, the question is what is clinically acceptable? And in this case, the threshold is even more blurry, depending on the situation that we find ourselves in. And for example, this is a microscopic hair picture, and the hair is about 100 microns in the thickness. And our patients can feel the difference and interferences of 20 to 64 microns, so less than half of a hair thickness the patient will feel, and with implants on both sides the number is even larger. So we need to be careful with our occlusion, because it's really the main factor of the longevity of our restorations. So to test these parameters, we come up with a quite extreme case, and we wanted to see how the scanners deal with both edentulous jaws and in the situation when we need to come up with maxillomandibular bite registration in these kind of cases. So it again, we had really precise reference scanner that we did scan of both jaws, and also an articulator. We measured the maxillomandibular distances, and then we came up with a silicone impression that we can use quite easily in our dental practice to fix it in between the jaws of the patient, and then we can record this maxillomandibular relation of the patient. Distances were measured between the corresponding metrological spheres, and then compared to the reference scanner measurements to get the information of how much deviations are present in this case on in vitro environment. So our results show that scanners performed quite similarly, and according to Trunas, the deviations were somewhere in between realm of 100 and 200 microns, and precision was about 200 to 300 microns. But as you see, the Carestream performed the worst out of the test scanners, and this was due to the scanner's inability to scan metrological spheres well. So we should take that with a pinch of salt when comparing Carestream to other scanners in this environment. And although we concluded that there was a statistically significant difference in terms of precision and trueness, but the only prime scanner presented results that were in realm of 100 microns. So this is the threshold that is cited in the publications, which is clinically acceptable and can be tolerated. But also, if we know that the full arch bite registration using these kind of extreme cases are not sufficient in most cases, how can we also improve that? What are the methods? So basically, we, as previously mentioned, we have these kind of fabricated individually stents for the patient, where we can utilize them not only to improve the implant scanning accuracy, but also use this to improve the bite scanning accuracy as well. So two shots in one. This is really convenient, but also it needs another visit to be produced, and also additional costs are involved. One of the more interesting solutions was presented by Nuitens et al., where they figured the implant scan body design, integrating those retractable parts to create a rest for the mandible or the opposing jaw. And in this way, you can get to stable occlusal points and then scan it. And in his research, Professor Nuytens with colleagues noted that with this methodology, you can expect deviations of around 800 microns, which is really not acceptable for the final restorations. But if we consider going from nothing to fixed implant restorations, temporary restorations, then this is a really convenient and fast way to fix the vertical dimension, and then we can adjust those few hundred microns in the mouth with the patient and let the patient with nice fitting, occlusally and aesthetically good looking teeth. Also, we did a study on pre-preparation technique, which involves bite registration before implant placement or utilizing the removable denture as a reference point when scanning implants to transition from removable denture to the implant fixed denture. And in this research, we similarly did articulate a few models into articulator, used metrological high accuracy scanner as a reference for the reference. And then we did a quite standardized scanning technique. So the lower jaw, the upper jaw with removable denture, with a cutout hole in the palatal area of the maxilla, then usual and standard implant scanning protocol. And then we compared three different scanning strategies for bite registration. So as you see in different colors, the first scan was done without anything, just in centrifugation that the patient holds by itself. Then the silicone putty index for the patient to bite into. And also the mentioned pre-preparation removal denture technique, in which case the bite was fixed and recorded with removal denture put inside. So these were the three groups of our research, and we did 10 times 10 scans per each case. Yet again, we measured the distances between the corresponding metrological spheres, and we did comparison to the reference scanner and in between the test groups. And we found some statistically significant trueness differences between the pre-preparation and other bite registration methods. And this suggests that these kind of pre-preparation techniques with removal denture should be used with caution, because the results indicate bigger occlusal deviations than other two methods. There was no statistically significant difference regarding the precision. And we concluded that this technique is less accurate than other used techniques, but we need to have in mind that the cutout hole in the palatal area was relatively small, and with bigger visible palatal area for the scanner, the results should improve. But clinicians should be careful in using these kind of methods to produce accurate bite registration in the full arch implant cases. And to conclude, Byte scanning might be most accurate when system tries to align data without any reference objects. There is no supplementary geometries involved in byte registration scanner field. The preparation method could be promising due to its ease of workflow, and also this preparation technique can be used with existing fixed restorations or the mock-up try-in restorations that are screwed onto the implants. So in this case, you get better visibility of palatal area, and you can expect better accuracy. And as I mentioned, byte registration is the topic that is not getting much attention in research on digital technologies and scanning. So in the future, more in vitro and also in vivo trials should be done to standardize and provide more information for clinicians on how reliable these technologies are. And also we deal with lots of new brands and scanners from the companies that are coming up every month. So including those new systems should be mandatory in future researches. Wrapping up my lecture, if you'd ask me how accurate is accurate, I would say it depends. Regarding the implant scanning accuracy, I would say 50 microns is the biggest discrepancy that we can clinically tolerate. And there's a lot of methods how can we improve our scanners, and with proper methodologies and the knowledge of the professional dental and dentist team, we can achieve those numbers and work in a full digital workflow. And regarding the byte scanning, it depends, and we can have 20 microns discrepancy, and we then will have to adjust the restoration if the patient is more sensible about his occlusion. And if this is conversion the patient from the removal denture to the nice looking temporary prosthesis after oral surgery, after replacement of the implants, then I can deal with even few hundred of microns of discrepancy, adjusting it to the satisfactory level, but knowing that I can deliver the patient the prosthesis maybe in few hours after the surgery, and he can leave the clinic with the functional and good-looking teeth on the implants. So thank you very much for your attention. I hope you got some insights and updates on the implant scanning and byte registration regarding the full arch implant cases. Thank you again, OIC, for this invitation, and we'll see you in the future.